So looking at a couple of other examples here, asthma, hay fever, and anaphylaxis. This could result from an allergic reaction to some sort of substance, whereas asthma is an acute spasm of the smaller passages. So hay fever, that's pretty mild. Even though it may cause, some irritation, it's not usually life-threatening. Whereas anaphylaxis and potentially asthma definitely can be. And so what you see here is a picture of a normal bronchiole and an actual narrowed, constricted bronchiole, and you also see some mucus beginning to form here. And so let's take a look at this. Asthma can affect all ages, but is most prevalent in children between age 5 and 17 years, and it produces characteristic wheezing coming from those narrowed bronchioles. An asthma attack can be caused by an allergic reaction to food or allergens or some type of severe emotional distress, exercise, or respiratory infection. So it really just depends on how severe a person's asthma is and what their triggers are, what causes them to actually have an attack. Again, hay fever causing cold-like symptoms from allergens including pollen, dust mites, and pet dander, so a little bit more mild. And anaphylactic reactions are going to be way more severe, life-threatening allergic reactions that produce severe airway swelling. Total obstruction is possible. And remember, I said your trachea is only the size of your pinky finger. So total obstruction, if it were to continue to swell, is possible. Epinephrine is going to be the treatment of choice for this, as well as oxygen and antihistamines. And so we talked about this previously in shock, but also we'll have an entire chapter with immunologic emergencies. But just remembering that epinephrine needs to be the medication that we lead with someone in anaphylaxis. That's what's going to save their life, is the vasoconstrictive and bronchodilator properties. And then also, again, considering oxygen and antihistamines if the patient can swallow, because our Benadryl can only be given by mouth at the EMT level. And then also, if the wheezing is really severe, then administering an inhaled bronchodilator like albuterol or Xopenex. So again, when we have these constricted bronchioles, that's where we would want to explore that treatment. Looking at spontaneous pneumothorax, a pneumothorax is an accumulation of air in the pleural space, and this is most often caused by trauma. So it can be caused by blunt or penetrating trauma, but it can sometimes also be caused by medical conditions, which is what is a spontaneous pneumothorax, where there is no trauma. And essentially that vacuum-like pressure inside of the pleural space is lost. And usually you have a bleb, is what they would call this weak spot on the lung. So it occurs when you have a lung infection or lungs that are already weak. And that hole is created on the inside. So normally, if this was from trauma, that blunt or penetrating trauma would have caused this injury. But when it's medical related, we are calling that spontaneous pneumothorax. And the patient would begin to experience dyspnea. And just like if this was coming from a traumatic related case, we would see decreased chest rise and fall on one side, diminished or absent lung sounds on one side. And so that air needs to be relieved. And the treatment for the spontaneous pneumothorax is the same for any pneumothorax where we have that air collecting, and that is going to be with a needle chest decompression. Now, our ALS personnel can perform the needle chest decompression, so it's important for us to call for them or meet up with them if we don't have time to wait on scene. And you should see some immediate improvement in the patient once they've experienced that needle chest decompression. Looking at pleural effusion, one potential way that a patient might be having dyspnea. So this is collection of fluid outside of the lungs, and it begins to compress the lung and cause dyspnea. It can stem from irritation, infection, congestive heart failure, or cancer, and usually the patient will feel better sitting upright. So not much that we can do for this in the field. Position of comfort and apply oxygen if necessary if the patient is really short of breath, and get them to the hospital for further treatment. Looking at the airway obstruction, this is something that we talked about in your initial CPR with the foreign body, but just so that we can go back and think about this, if we have someone with a mechanical obstruction, so an actual foreign body that is there, like food or some other object that's blocking the airway, remember, if they are still conscious and they're coughing, we want to encourage them to cough. If they are conscious but not coughing or moving any air, then we want to perform the Heimlich maneuver. If they are, we would perform the Heimlich maneuver until the object comes out or until the person goes unconscious. If the patient is unconscious, then we would want to go ahead and begin CPR, stopping to look in the airway before giving each set of breaths to determine has the object come up or not. Now, we also want to look into the airway for other obstructions like vomit or fluid or blood that needs to be suctioned out, or it could be that the tongue is what's blocking the airway, in which case we would manage that with a head tilt chin lift or a jaw thrust maneuver, whatever is the most applicable for the patient. Remember, jaw thrust maneuver if they have a potential for spinal injury, and head tilt chin lift if they don't. Looking at pulmonary embolism, this is a blood clot that circulates through the venous system where circulation is cut off or partially cut off and can significantly decrease the blood flow. If it's large enough, it can cause sudden death, but usually your patient's going to have some dyspnea as well as chest pain to that area. Red flags that we would want to consider would be if the patient has a history of clotting disorder, if they take blood thinning medications, if this is a woman of childbearing age who takes birth control medications, if this person has a sedentary lifestyle, so whether they are bedridden, wheelchair bound, if they are, sit at a desk the majority of the day, if they're truck drivers, those are people who have more sedentary lifestyles and are more prone to blood clots. And then also someone who's had a recent surgery. So all of those things could be potential red flags combined with your shortness of breath and sudden onset of chest pain. Looking at hyperventilation, this is over-breathing to the point that the arterial carbon dioxide falls below normal. And so this could be an indicator of a life-threatening illness if it's happening because of some other reason than emotional upset. Usually where we see patients hyperventilating would be with someone with anxiety or something, emotionally upsetting has just occurred and the patient is able to be calmed down. But it can also be happening as the body attempts to compensate for changes inside of the body as well, like acidosis. And so that's where it starts to become more concerning if it's not something that can be controlled. Hyperventilation, if it's not stopped, can result in alkalosis, which would be the buildup of excess base in the body. So that's the opposite of acidosis. And this can cause symptoms of a panic attack like anxiety, dizziness, numbness, and then tingling or painful spasms in their hand or feet. So that's really important for us to see if the patient is complaining of that hand cramps or dizziness and tingling in the hands and feet, that's a concern as well for us to think about. So we want to identify what is causing the hyperventilation, and then is there anything that we can do to correct it. Looking at environmental and industrial exposures, so chemicals that the patient may have come into contact with that could be contributing to their dyspnea, pesticides, cleaning solutions, chemicals, chlorine, and other gases that the patient may have been exposed to. Also thinking about things like carbon monoxide, which is a silent killer. It is odorless, very highly poisonous, and produced by fuel burning appliances and smoke. That's why we have such a high prevalence of those types of issues over the winter time, or fuel burning appliances, and the patient does not realize that's what's happened. They go to sleep and unfortunately die in their sleep. So definitely something to be concerned about. We never want to put ourselves at risk, so we want to look and see if there are more than two people, or rather two people or more in one place with the same symptoms, whether that is headache, nausea, unresponsiveness, anything like that. We do not want to enter that area because we're putting ourselves at risk. And again, if you got 2 or more people with the same symptoms, that's bad. Something is in that area and they need to be removed from it. So you would wait for the hazardous materials team to arrive and move the patients outside, or if they're still conscious and can follow directions, you could give them some directions over your PA system for them to meet you outside. So just looking at some scene safety considerations, making sure that we're utilizing standard precautions and PPE to protect ourselves. We want to consider the possibility of infectious disease and toxic substances that could be dangerous to ourselves as well. Looking at the mechanism of injury and nature of illness, asking why 911 was activated, and questioning the patient, family, bystanders, or caregivers to determine the nature of illness. We want to identify and treat any immediate life threats while forming our general impression, looking at the patient's age and position, especially looking to see, are they in that tripod position? Are they, to appear to have a high level of distress? Is the patient alert? Are they oriented? We want to ask about chief complaint. We also want to take a look at breath sounds here, looking for chest rise and fall, and then listening top, bottom in comparison to listen to the rate, the rhythm, and quality of respiration and any abnormalities with lung sounds. We're going to look at circulation, the rate, rhythm, and the quality of the pulse, looking at the blood pressure, skin color, temperature, condition, making our transport decision, and determining, do we need any assistance here or should we proceed with rapid transport? As far as history taking, we're going to, again, like we said, investigate the chief complaint, get our thorough sample history, and we can ask OPQRST questions, which, remember, are going to be most related to pain. And so that's going to be a little bit more related to chest pain and abdominal pain. You can use the PACE assessment for difficulty breathing, which is going to ask about progression, associated chest pain, any type of sputum that they've had, talking tiredness, and exercise tolerance. So again, how did this come on? Was it slow? Was it fast? Do you have any chest pain with it? Have you had any sputum that you've been coughing up? If so, what did it look like? Was it blood tinged? Was it frothy? Was it a little bit? Was it a lot? Was it mucus? Talking tiredness, are they able to just speak 1 or 2 words between breaths? And then exercise tolerance, can they walk to the mailbox, or does that give them completely out? And if those 2 things, the talking tiredness and exercise tolerance, is that what's normal for them? How long has that been going on like that? As we're looking at our secondary assessment, we're going to do a more in-depth assessment of the body systems after we've addressed any potential life threats. We can also make sure that we're looking for signs of COPD versus congestive heart failure. With COPD, just because of the way that a person has to change their breathing patterns, they often develop what's considered a barrel-chested appearance, as it actually changes their muscle structure. And with congestive heart failure, those patients often have increased peripheral edema, usually starting at the feet and the legs. So if you notice that those are really swollen, ask them, is this normal for you? Is it more swollen than normal? How long has it been like this? Have they had a weight gain? If you're having trouble distinguishing between those lung sounds, think about other things that could be the deciding factors between these 2 conditions. And then as we reassess, we're going to repeat the primary assessment again every 15 minutes if the patient is stable and every 5 minutes if they're not. We want to administer oxygen to any patient who's having dyspnea first and foremost, again deciding whether we need nasal cannula or non-rebreather. So consider positive pressure ventilations, airway management techniques, positioning. Remember, position of comfort is always best, especially when it comes to respiratory. And then assisting with other respiratory medications like inhalers, or are we in a position to administer a neb treatment to our patient? Pretty much the same thing that we just talked about, the utilization of meter dose inhalers or nebulizers, contacting medical control and making sure the medication is indicated if necessary. Remember that for the state of North Carolina, with our 2 bronchodilators, albuterol and Xopenex, the patient needs to have been prescribed those medications previously for us to administer, or we need to contact medical control. So it doesn't mean that we can't give it, it just means that we need to contact medical control before we can administer it and get their permission if they've never been prescribed. So I'm going to stop right here for this portion of the video, and I'll catch you guys in the next one.